you're dealt, but there are no bad cards in this deck. So.
All right, thank you so much. Moving right along, we have Gelu Negrea from the Lebanon VA Medical Center with the Central Booking Project, Early Identification of Justice-Involved Veterans.
Good afternoon, everybody. My name is Gelu Negrea. It's a very common name. I'm sure people have heard that before, right? So anyway, I'm a Veterans Justice Outreach social worker from the Lebanon VA Medical Center, and I've been doing VJO since 2014. So one of the issues that I've discovered in VJO is a major problem is identifying justice-involved veterans. By the time veterans are identified and returned to myself and other VJOs, they're already facing major charges with extensive jail time attached. So an example of that is a recent veteran that I'm actually currently working with now. He was in trouble. He picked up charges in 4 separate counties before that veteran was ever referred to me. And he's facing like 5 to 10 years now. Again, because he moved around a lot, was not identified early enough, he picked up a lot more charges. And this is a combat veteran with substance abuse issues at all as well that has not received any treatment, that if we could have identified early, we could have gotten him involved in a lot of the treatment that we already offer at the VA. And a lot of, one of the other things I want to mention before I move on with this is a lot of the studies show that recidivism rates are about 70% when somebody gets in trouble with the justice system. So if they get in trouble with the justice system and they do not get treatment, it's a 70% chance they're going to get involved with the justice system again. So that's a large problem. I would rather we could help veterans before they're referred to me facing significant time. So that's where the Central Booking Project idea came from. So this led us to ask the question, how many veterans are justice involved in our counties? How does the county identify these veterans and track them? And that's kind of a complicated question. So again, every county does things slightly differently. So that's a little bit, that's hard to, they really were not properly tracking it. Some of them were, some of them weren't. So this actually led us to ask the question then, this resulted in the development of the Central Booking Project, where I proposed that each county and central booking location should be asking every individual coming in contact with the criminal justice system, did you serve in the military? It's that simple. When a veteran goes to booking, to ask them, did you serve in the military? And then if they did, they could send that information to the VJOs to verify their service and help get them enrolled and offer them services early on, because everybody goes through booking, not everybody goes to jail. So that's the earliest possible intervention point that you could get them. So at this point, okay, so the idea so far, so the idea is help the VA identify unique veterans that have not been reached by traditional outreach and offer them services to enroll them for healthcare services. So at this point, for example, Lebanon VA, we have 9 counties in our catchment area, and we have 3 counties that have implemented the Central Booking Project. And in the past year with these 3 counties, we have had 1,800 referrals. 1,800 referrals, and out of those 1,800, 25% are VA eligible that are unique, that have not been enrolled. So that's almost 400 veterans out of those 3 counties alone that we have been able to at least offer services early. So that's pretty impressive so far. Another important statistic that I'd like to mention is that in one of our counties, we were able to identify 46 veterans that had upcoming legal charges that were not referred to veterans courts yet. So I think that's an important aspect as well. So far, the community stakeholders have been very receptive to the Central Booking Project idea. The Association of Problem Solving Courts has invited me to to participate in the strategic planning committee for veterans courts to maybe, hopefully, we could implement this statewide. So it's been very well received. Some of the issues that maybe we've encountered is higher than anticipated referrals, and then each county is very unique and they don't have a standardized process. So that's all I have. Thank you.
All right, next up from the VA Pittsburgh Healthcare System, we have Dr. Bandi with Diabetes Care Network, a paradigm shift in diabetes care.
Oops, I missed it. Hello. So, when you see this man jumping from one side of the mountain to the other, imagine if this was a veteran with poorly controlled diabetes for years, and finally he has an opportunity to see an endocrinologist who is just about 3 hours away. That's what it sounds to a veteran. So what we're presenting here is a pilot that we conducted over a period of 1 year, which is a telehealth-based collaborative care model. And we really want to modernize the care. We want to change the paradigm shift. And we did it with a team, a hub team at Pittsburgh, which is where patients get specialty care, and 2 pods in rural area. I have two of my team members in audience, and Ashley, who is a pharmacist out of another VA.
Thank you. So representing Vision 4 in the Western market, Pittsburgh is our hub, and we have, they're then affiliated with 4 spokes that they would provide a lot of the specialty care for. So we serve about 300,000 veterans in that Western market. So diabetes is definitely a major chronic condition across the population. It's even higher incidence in the elderly and even higher in our veteran population. So the traditional model is quite reactive, very fragmented. We do have electronic consultation, but they still are very limited in what they can do. We have frequent bounce backs from that, and then patient goes to face-to-face or video clinic, there is long wait times to that. So it's really silo. It's either primary care provider's patient or an endocrinologist patient.
So with the Diabetes Care Network, with me being at the spoke, I proactively identified patients with uncontrolled diabetes. You know, some of these patients live 2 to 3 hours away from the hub down in Pittsburgh. Travel is difficult. They're unable or unwilling, you know, to go to the hub for their care. Once they were identified, we consulted them to endocrine by e-consult or video telehealth. After the interventions were made by endocrine, then they referred us back to the spoke sites to continue ongoing management. With this virtual care delivery, the teams really work together to fully support the patient. You know, they never actually had to come see us, or some of them never even had to leave their home other than for lab work.
So while I labeled this as embodiment of chronic care model, after we just talked this morning, I really want to call it strategic architecture. And we do that because we use the clinical information system. We really changed the community around these diabetic patients. So we created, we used the population level data from corporate data warehouse. We identified these patients proactively, and we created the pathways to connect the two hospitals so patients are not in the silo, so that we are all serving the patient with the same goal. We used our existing delivery system, and we redesigned them only to work for patients on a continuity basis without fragmentation. So we used e-consult, video care, we used our care coordination and remote monitoring services. And at the core of it was the endocrinology team located at the hub, which was virtually available for the pods. And the pod liaisons were using all their local resources, such as PharmDs, nutritionists, nurses in the clinic, and the home-based primary care. And as a result of this community, what we had was very patient-centric care with predefined individualized goals. So you may ask, how did we do? So here are our results.
So as far as our results, you know, our cohort of 87 patients, they were predominantly male, a lot of comorbidities, elderly. They had a baseline A1C of 10%, which is very poorly controlled. That's an average of, how well controlled the diabetes is. After 3 months in those initial interventions, the A1C average did go down to 8%, and then at the 12 months down to 7.6.
So when you see this, or if any healthcare providers in audience, when they look at this graph, they say, wow, this is 2 or 3 drugs together and still not getting that on a consistent basis. More importantly was this, the patients who attained A1C less than 7.5%, the goal is less than 7, but these are elderly patients, so our goals are a bit relaxed. The percentage of patients who got to that goal continued to improve. So as Vijay said, what strategic architecture looks like, we had nonlinear shift, we had strategic intent, we address the current core competencies, we had our annual priorities. We wanted to help our primary care providers meet their performance measures, and we wanted to create new competencies. So working with me and other endocrine staff, the liaisons, they increased their skill set. They felt confident in using new agents. So where do we go from here? So we want to expand this approach for a wider audience, not just the veterans, for primary care providers. We want to strengthen our existing resources, and we want to create pathways. So that's what we did. Thank you.
Thank you, ladies. Next up, we have Clairmont Barnes, who's joining us from the Office of Mental Health and Suicide Prevention at VA Central Office with Getting Results in Transition, or GRIT.
Well, folks, if you don't have GRIT, Getting Results in Transition, before you leave today, I hope that you will download it and take a look and see what it can do. One of the risk factors that we have for suicide is being connected. Also, employment, finances, legal issues, and such. So to help combat this for not only service members, veterans, spouses, anyone going through a transition, we have a technology solution that we partnered up with IBM to develop for us to try to get at this thing that we call suicide. All right, come on up, Mark. Mark Newsom with IBM.
So I'm going to give you a very brief overview, live demo of GRIT. I'm actually inside the app right now that you see up on the screen. As Clairmont talked, there are 4 aspects that we're looking at inside of here in partnership with the VA to be able to develop resiliency, focusing on the social determinants of health. Far up the stream in suicide before an individual spirals at the point of transition. This is generally 1 year to before they retire from active duty or come off active duty to 1 year after they're off of active duty. But at any point of transition, this is available for veterans. The first use case developed by the VA is employment. There are 4 aspects: mental fitness and resiliency training, personalized job matching, employment, support from your squad, and I'm actually inside the app now live, and a digital assistant to answer any questions. If we went over mental fitness and resiliency, we partner with Total Brain, one of the foremost agencies in the country for mind fitness. And we're using their technology to leverage up on here for an environment for veterans, service members, caregivers, and spouses to use to improve their mental fitness. Just as you go to the gym, this mind gym is the same thing. Personalized job matching, we're partnered with Burning Glass. They aggregate about 51,000 job sites and produce about 198,000 jobs every single day for our veterans and those using the app. Support from your squad, you develop your squad just as you were in the military and you're used to that community of individuals that would be concerned with you if you were in crisis. When you're not in crisis, you identify those individuals so that you have to have and maintain that social connectedness when you're off of your baseline after you do your assessment inside of the mind gym. And then a 24/7 digital assistant. We're leveraging artificial intelligence up under here in the digital assistant and also in the mind gym to make sure that this is proactive towards the veteran and not reactive, and that they get what they need. If I would just show you a few of the aspects just a little bit. Our mind gym, it heat maps out where you may be in a particular area: emotion, self-worth, resiliency, depression. The more full the heat map is, the better you are. But it doesn't just stop there when you're inside of here, but it gives you exercises that you can use to improve where you're maybe lacking in anxiety, depression, social well-being, and so forth. The squad, you identify those 5 or 6 individuals that you would want if you were in a crisis. So since you're not in crisis, you identify those individuals, and when you're off your baseline from the original assessment that you take inside of the Mind Gym, through artificial intelligence, it reaches out to you and say, hey, Bob hasn't been to the gym in 4 or 5 days. You might want to invite him out for a cup of coffee. So it's a very warm touch, not a very involved touch, and not an alarmist, but it's a very soft touch. We just completed the first wave of field tests of about 3,000. The early results are the individuals that are inside of there are using this on average 16 to 17 minutes a day inside the Mind Gym. That is far above the average for deployment of an app. So feasibility, adaptability, usability, they're using it at a high rate. We're entering the second phase of field tests now. We expect another 3,000, and then we look to go into production at the end of this year, January timeframe. You have in your hands there, if you take your phone and take the QR code on the back, if you're a caregiver, spouse, veteran, or service member, you're able to participate in the field test as it is right now. You'll get an email, and then a second email is when you can download the app and use it on your phone, just as I am now. Thank you.
All right. Next up, joining us from the VA Northeast Ohio Healthcare System, we have Andrew Harris with the Hypertension Patient Aligned Care Team, or PACT, a population-based intervention to improve blood pressure control.
Hi, good afternoon. I'm Andrew Harris. I'm a primary care doctor at the Cleveland VA, which also means that I have the best job in the world, and I work for the best organization in the world. So I want to tell you a little bit about our seed investment that we had on managing blood pressure within PACT teams. So just for background about hypertension is very common. Nearly half of all veterans have hypertension, and of those, about 500,000 are uncontrolled, meaning their most recent blood pressure reading was over 140/90. We also know that uncontrolled hypertension causes a lot of morbidity and mortality. Estimates are that about 1,100 preventable deaths per day in the United States can be attributable to uncontrolled hypertension. There's also good data out there that there are population-based interventions that have worked well to reduce blood pressure, and I think we, using our Box One mind, wanted to go out into the field and see what was working, but then also bring in the strengths that we have within VA, which are many, in order to achieve good gains in blood pressure control. So just at a high level, a simple way to think about the framework is that we want to diagnose accurately, we want to treat with evidence-based interventions, we want to act rapidly to make sure that whenever we do intervene, that we get improvement and we get the results we're looking for, so we get feedback on how we're doing, and then we can tailor treatment for success, utilize our team members to do that. And then lastly, we want to close the feedback loop, which means we want to reach out, we want population-based tools that will tell us who's out of control, who's lost to follow-up, so that we can bring those people back in, because you can't control the blood pressure of a veteran that you're not seeing either in person or virtually. Then underlying that thread was our ongoing coaching at weekly team huddles with performance coaches. Performance monitoring, meaning we give the data back to the clinical teams. We also give them patient-level data so that it's much more easy for them to interact with. And then frequent pilots and small tests of change. I will give a shout out to our colleagues with the Video Connect for blood pressure, because we were trying to do that too. So I'll if you're not in the room, I'll reach out to you later to help us get that up and going. Before I give you the data, what makes this successful? So what is it about the VA that makes this work? So far and away, high performing PACT teams. And if they're not high performing, then support them through coaching for performance. So I would say those were the two things that were key to the success. I I think the people that work in primary care believe in the mission. Primary care is effective for preventive health and health maintenance and chronic disease management. Then secondly, the VA is blessed with a lot of data, rich population level data that you can use to make clinical decisions and do outreach. Next is the interdisciplinary approach, and that's tied to number one, high functioning PACT teams. When you have all of your team members pulling in the same direction for the same goal with clearly defined roles and tasks, then you get more bang for your buck. And then lastly is the veteran engagement. They want to do better. When you work with them, when the whole team works with them on the importance of this problem, their role in self-management, teaching them how to check their own blood pressure, giving them blood pressure cuffs, video connect, and those modalities, they get engaged in the process, and you have a recipe for success. So what were our results? So when we started, we piloted this in 2 PACT teams with about 900 patients that had hypertension. We moved from about 63% control in February to 72.6%, almost a 10% improvement over that 8-month time period. And if you look at the raw numbers, an additional 109 patients got their hypertension under control during just 8 months. So what were some of the lessons we learned? Number one, I think clinical teams drive innovation. So using the coaching model, having them involved, doing human-centered design. The teams they know the problems, they will tell you the solutions. I have too many examples to give you, but if you ask me later, I can tell you more specifics. So we had a framework, but we were flexible, and we let the teams work within that, and we weren't just giving them a cookbook recipe to follow. Data is necessary but not sufficient, so it's good to have it, it's great to have it, but it needs to be usable for the team. So having patient-level data that's actionable that clinicians can use is most effective. Regular team meetings, common targets, and then lastly, I would say we were very intentional about emphasizing the process over the outcomes. Even though we were giving regular feedback, it wasn't used as a hammer so much as it was to say, we're with you, stick with the process, and you'll see the results improve over time. So thank you.
All right, thank you, Andrew. Great job. Next up, we have Jessica Homan from VA Central Ohio Healthcare System with the Lesbian, Gay, Bisexual, and Transgender Champion Education Train the Trainer program.
Good evening. Thank you all for sticking with us this late into the day. My name is Jessica Homan. I am the LGBT Veteran Care Coordinator at the Columbus VA, and I'm also the LGBT Veteran Care Coordinator Vision 10 lead. Last year, I received a seed investment to conduct our first LGBT education champion program. And this year, we expanded that through the SPREAD program from a 2-day training to a 3-day training, and also made it a Train the Trainer event. So the LGBT population has a long history of discrimination, not only within the military, but in our society as a whole. Since its inception, the military has had discriminatory policies against LGBT people. In our society, only a few years ago, did same-sex marriage become legal in all 50 states. With military experience, Don't Ask, Don't Tell wasn't repealed until 2011, and there is currently a trans ban under our administration now. But there's discrimination in healthcare settings too. I'm going to give you a couple of examples of some of this discrimination that's happened at the Columbus VA specifically. So there was a transgender man who came in who has had a hysterectomy and who was made to take a pregnancy test. We had a gay veteran who has been in a monogamous relationship for 20 years with his partner, and his provider asked him every time that he came in to take an HIV test, even though he was not at risk. I had a transgender veteran come in to see the GI clinic with stomach issues, and the provider asked about their genitalia just because they were curious. And there was also a woman who came into primary care and was screened for intimate partner violence with her partner sitting next to her. So there are issues in Columbus, but there are issues in all healthcare settings related to LGBT education and health disparities. So this is a high-risk population. The needs are different. The LGBT population has a higher risk for suicide, for being victims of military sexual trauma, for substance use disorder, and other mental health issues. So LGBT people are 3 times more likely to have a mental health condition than the general population. Men who have sex with men are 4 times more likely to attempt suicide than the general population. And there's something called the National Transgender Discrimination Survey, which had a sample size of 28,000 transgender people, and 41% of that survey respondents stated that they have attempted suicide in their lifetime. 41%, that is huge. So how can we better serve this population? We decided to take the road of education and educating our clinicians to make sure that we have the best environment for our veterans. So for this spread project, we went and spread it to 15 different VAs. We had 2 representatives from each VA come to participate, 1 facilitator and 1 prescriber. And we covered topics over a 3-day period that included LGBT 101, intersectionality, PrEP and PEP, which is a preventative HIV treatment, and many other things as well. So what makes this program stand out? How is this different from any other LGBT training that you can go to? For us, for our pre and post testing, we hired LGBT patient actors, and we had each of our clinicians perform an initial assessment with them where we observed them and scored them on certain data. Some of this data would be asking identified name and pronouns, talking about the LGBT identities that are protected by HIPAA and what goes in their chart, and mentioning the LGBT Veteran Care Coordinator. We had very positive feedback. We're still collecting information from the train the trainer aspect, as several of the sites are initiating doing this at their facilities and in their VISN. But some of the feedback from our participants during the pilot study was, what surprised them most was the diversity of topics and wanting more time to actually learn, and also having their attitudes changed about interacting with transgender people, feeling more relaxed and like they can relate to those patients. So my hope for this project is that all LGBT veterans and all veterans in general feel comfortable and safe coming to the VA and safe coming out to their providers. And I hope this can be used nationally, treat all of our veterans with dignity and respect, and that we can all be a champion. Thank you.
All right, thank you very much. Next up, we have Cassandra Simic and Sara Schoen from the Milwaukee VA Medical Center here to tell you about their Milwaukee food donation program.
Hello and good afternoon, everyone. So through the collaboration between Nutrition and Food Services, the Green Environmental Management System, the Treatment Alternative Group, and the HOPTEL, we've implemented a process at the Milwaukee VA that's changing our veterans' lives. My name is Sara Schoen. I'm the Administrative Dietitian for Nutrition and Food Services at the Milwaukee VA.
I'm Casey Simic. I am the GEMS Program Manager for Milwaukee VA.
So our process first started in the kitchen when our food service workers were noticing a lot of trash after each meal period. So this was understandably upsetting for them, so NFS management worked with the GEMS group to see how we could reduce some of the waste that we had. And through the pilot studies that the GEMS group put together, we found that we were throwing away nearly 500 pounds of food from our tray line each week. Now, if we were to project this out to the VA as a whole, this is nearly 4 million pounds of food being landfilled every year.
And unfortunately, the problem of food waste is not unique to the VA. The Environmental Protection Agency estimates that 22% of landfills are composed of food waste itself. It's also a significant contributor to greenhouse gas due to the production of methane upon decomposition. NFS management started looking into food forecasting and inventory management in order to bring this waste down, but there was still going to be food remaining. We decided to look into the possibility of food donation. Unfortunately, traditional avenues like donating to a nonprofit organization like a food pantry proved logistically challenging, and we also ran into a lot of red tape due to VA property regulations. So instead, we decided to look to on-site programs. We looked at Treatment Alternative Group, or TAG, which is a program designed for veterans who struggle with substance abuse. Many of these veterans also have food insecurities, which basically means they don't have immediate access to nutritious, wholesome food, and they often don't know where they're going to get their next meal. We also reached out to HOPTEL, which is designed for veterans who live over 50 miles away from the VA campus, but they're in need of overnight stay in order to receive outpatient services from the VA hospital itself. Both programs are really interested in receiving this food. So now we just need to figure out how we were going to go from a process of just throwing food in the trash, which is fairly simple and easy, to packaging it up, storing it, transporting it, and serving it to the veterans in a safe manner. So this is what we came up with. NFS staff packages up the food after meal service. They send it down to the kitchen to freeze. Facilities management picks up the frozen food and delivers it to TAG, which is located in a different building. Veteran participants in the program prepare the meal, thaw it, and then serve it to their fellow veterans after group therapy sessions. So this is a picture of veterans sharing some of the meals that we gave them. You can also see one of the veterans is put in charge of preparing and serving the meal, which actually gives him an added sense of responsibility and purpose, which aids in his therapy program itself. The program has really gained traction. Management has reported that participation in TAG has increased by over 30%. So they went from about 11 to 12 per group therapy session to up to 28 per therapy session, and that was only after meals were introduced.
Now, as a result of this program, NFS has donated nearly $5,200 worth of meals that would have otherwise gone to the trash. And so one great aspect of this implementation is that there's no additional food cost to run the program. It has also significantly cut down on our CO2 emissions. And post-implementation, we've not only increased TAG participation, but we've received a lot of positive comments from NFS staff who now notice far less food waste. So we're here today to share our toolkit with other VA facilities. So we address the government, the regulatory, and the liability aspects of food donation. And it did take a lot of buy-in with other departments within the VA, so we have created a procedure and an MOU to share with everyone. And now the takeaway here really is that the VA can reduce their environmental impact, we can feed hungry vets, and we can improve outpatient programs through food donation. Thank you.
Moving along, we want to welcome up Ann Keough from the Memphis VA Medical Center for her project Reducing Concomitant Utilization of Opioids and Benzodiazepines, Saving Veterans' Lives.
Thank you. Thank you for that introduction. Once again, my name is Ann Keough. I am a clinical pharmacy specialist at the VA in Memphis, Tennessee. Today, I will be discussing our process of reducing concomitant utilization of opioids and benzodiazepines. So unfortunately, in today's culture, it is not uncommon to know someone who is affected by the opioid epidemic. According to the NIH, 130 people die every day from an opioid overdose, and veterans are at twice the risk of overdose than non-veterans. Taking an opioid with a benzodiazepine medication like Xanax or Valium actually increases this risk exponentially. Recent data tells us that veterans are actually 4 times more likely to die from an overdose if taking both medications together. So recognizing and addressing this potentially dangerous combination is really of utmost importance. Our VA, DOD, and CDC guidelines now recommend against using both of these medications together due to these risks. So focusing on that recommendation, our facility set out to implement a plan to reduce concomitant use utilizing a prior authorization drug request, or PADR. This was developed in collaboration with key stakeholders from our leadership, ambulatory care, mental health, pharmacy, and our local opioid safety initiative group. So prior to implementation, we provided a mass education to both providers and veterans, detailing the risks of taking both of these medications together. All veterans that were identified as receiving the combination were mailed informational letters, as well as safety brochures from our academic detailing office, and they were told to expect a conversation with their provider in the upcoming months. Once our prior authorization drug request went live, any veteran who was receiving the combination was required to have this request placed by their provider. So veterans who were on hospice or receiving a short-term supply were approvable. Any veteran that was receiving the combination chronically was required to implement a safe tapering plan of one of the medications to cessation. And this is where we enlisted help from the veteran in this initiative, because the veteran was the one that actually chose which medication that they wanted to safely taper off of. All of our requests were reviewed by one of 3 clinical pharmacy specialists every 90 days, just to ensure that the plan that was documented was being carried out safely and appropriately. So as you can see here, the Memphis VA has substantially reduced the number of our veterans receiving both opioids and benzodiazepines. We started with 596 veterans on the combination, and after process implementation, only 9 veterans remained, which represented a 99.5% reduction in dual use. We did do a retrospective study looking at our process outcomes, and it revealed that the majority of our veterans actually chose to taper off their benzodiazepine with an average length of taper of greater than 90 days. And really importantly, in 80% of veterans, therapeutic alternatives were implemented that were safer and more in congruence with current clinical practice guidelines than the opioid or benzodiazepine might have been. So in summary, through a collaborative approach and an educational campaign, we were able to significantly and safely reduce the number of our veterans receiving both opioids and benzodiazepines, all while giving the veteran a choice in their own health care. Our team is really excited to have achieved being #1 in the nation for this metric, as well as winning the 2018 Undersecretary for Health Excellence in Pharmacy Practice Award, being a top 20 status in the 2018 Shark Tank competition, and spreading to other sites within our VISN, as well as the Pittsburgh and Tuscaloosa VA. So through implementation and spread of our innovative practice, we have saved veteran lives. Thank you.
All right, last but not least, we have Ms. Debra Winningham Short from the VA Central Ohio Healthcare System with the Save a Warrior Aftercare Program.
Save the best for last. Hi, my name is Debra Winningham Short. I'm the Innovation Specialist at Central Ohio, and I am also an Army combat veteran. Cool. The United States military is the best in the world at taking your average everyday Jane or Joe and molding them into an elite, skillfully trained fighter, critical thinker, and warrior. We figured this out very well. It's ingrained in us. The problem is when we come home, it's still ingrained in us. That doesn't go away. I'm still a fighter. I'm still a critical thinker. I'm still a warrior. And you add to that being a steely-eyed killer or someone who's expressed trauma. So how do we cope? Sometimes it looks like becoming an entrepreneur or a contractor. Other times it means becoming one of the 22 veterans who commit suicide every day, or losing my family or my job or my home to PTSD. When I heard of Save a Warrior and their peer-led model, I knew that this is something that could be an answer. So we wanted to measure the effectiveness of the program.
I'm Michelle Atkinson, and I'm from Save a Warrior. And our purpose is to combat veteran suicide. Can I get a me too? Yes. We can't do it alone though, and we're very fortunate to have been able to partner with the VA and have this investment to really expand our aftercare program. We've been working very closely with the Columbus, Ohio Chalmers VA on how to better serve our veterans suffering from post-traumatic stress and suicidal ideation. What we did was we sponsored 9 Ohio veterans to attend our 5.5-day integrated intensive retreat. And we're following them for 2 years on their healing journey. what we do over the 5.5 days is we introduce the veterans to experiences that they wouldn't normally engage in with a group of other veterans, so people that are their peers. And we expose them to labyrinth walking, meditation, mandala drawing, storytelling, and we also do equine-assisted therapy, and we do high ropes courses and small group community resiliency similar to the anonymous community, like Alcoholics Anonymous, small group work. Sorry about that. So we are peer-to-peer. We have no clinicians on our staff. Everybody on our team are wounded healers, so they are veterans who have also experienced post-traumatic stress and moral injury, and they pulled themselves out of darkness and isolation, and they share that, and they hold space for the participants in our program over the 5.5 days. So they trust us a lot quicker, and they're more vulnerable, and it's through that trust that this collaboration really works. We're able to connect them to resources once they leave because they take us seriously. And as I've surveyed the 9 warriors who've been through our program, 5 responded, but 4 out of the 5 have re-engaged or enrolled in their local VA since coming through our cohort. So to measure the stickiness of our program, we have an alumni affairs director who his sole job is to make sure that our alumni are doing okay once they leave our program. We use the same surveys administered by the VA to measure post-traumatic stress, suicidal ideation, and depression. And what we've noticed is a decrease in those scores. So on the SBQR, it doesn't really move over the first 12 months. You don't really see a big difference. We'd like to make sure that they haven't had a life-altering impact that changes them. So we really focus on that question 4, how likely are you to attempt suicide? And we see a decrease in that. On the PHQ-9, we see about a 43% decrease in their scores over the last 3 months, and it's below that threshold, that at-risk threshold. And the same thing with the PCLM. We see a decrease of about 26% in the scores, and again, it's below that at-risk threshold. And over the next 18 months, we anticipate to continue to see these scores decrease. I'll let Debra kind of talk about what the next steps are.
So what I've learned since we started this pilot and did it as a result of our Spark Seed Spread investment last fiscal year are 3 things. I've learned since that the VA doesn't have the best model for continuity of care once behavioral health care has been established outside of the VA as opposed to initiated within the VA. I've learned that there are still more veterans who do not trust the VA than do. And I've learned that the experience of getting help, the help you need when you need it, isn't always perceived as just in time when the veteran comes to us for services. So this year we received another investment to do this with an all-female cohort. We want to measure the program's effectiveness to see if the same outcomes can be repeated, and we'll also be adding a pilot to establish a process that addresses improved continuity of behavioral health care. Thank you.
All right, let's give that entire group of presenters one more round of applause. All right. So just a couple of housekeeping items before we close for today. Just a huge thank you again to our presenters, to our timekeeper, to our judges. Thank you all very much. Remember, if you're enjoying the event, make sure that you're posting and tweeting and sharing that love on social media. Don't forget to attend the awards ceremony tomorrow, which will start at 4:30 p.m. right here in the ballroom, where one presenter from each track will be selected to receive an award. So excited to see that. And tomorrow the day will kick off with the opening of the Experience Center, and that will open tomorrow at 8 a.m. You can come see some of the 3D printers in action and some other incredible exhibits. So make sure you don't miss that, and join us again tomorrow for more demonstrations and presentations in both the morning and afternoon. All right, thank you all so much. Have a great evening.